Hi, everyone. My name is Danielle Gatti-Palumbo, and I'm a clinical pharmacist at the Division of Rheumatology at Northwell Health. And today I'll be presenting on the clinical trial Inhibition of Structural Damage Progression with the selective interleukin IL-23 inhibitor Guselkumab in participants with active PsA. And this was results through week 24 of the phase 3 randomized double-blind placebo-controlled APEX study by Dr. Meese that was published in Annals of Rheumatic Disease. So a little background is PsA is a chronic inflammatory disease that not only affects the joints, but also the skin, and can have a really significant impact on quality of life. And it can lead to joint destruction, erosions, as well as radiographic progression that is associated with impaired function and also can potentiate to disability. And early damage is very common, with about 25 to 39% of patients with early PsA showing already erosions, with up to 47% of patients with damage within those first 2 years of diagnosing. So even delaying the diagnosis by about 6 months has been linked to erosive disease with poorer functions. And the guidelines also recommend starting biologics pretty quickly in patients with active PsA, despite conventional DMARDs, especially if those patients have poor prognostic features that include any radiographic damage. So Guselkumab is a biologic monoclonal antibody that selectively and potently binds and inhibits the P19 subunit of IL-23, which is a key regulatory factor in the inflammation pathway of PsA. And it's dosed at 100 milligrams at week 0, 4, and then every 8 weeks for both psoriatic arthritis and psoriasis. And from what we know in phase 3 psoriatic arthritis trials is that Guselkumab has been shown to improve multiple key PsA domains, as well as physical function and also health-related quality outcomes versus placebo, with their benefits in these clinical trials sustaining up to 2 years with a favorable safety profile. But looking specifically at the radiographic outcomes, in the Discovery 2 trial, they saw that Guselkumab every 4 weeks had exhibited statistically significant less radiographic progression by week 24 versus placebo. And even in the 8-week dosing, it showed numerically less progression versus placebo, but it did not reach statistical significance. So this article looks specifically at the 24-week data from the ongoing global APEX study with Guselkumab every 4-week dosing, every 8-week dosing versus placebo, and looking specifically at clinical signs and symptoms, as well as radiographic outcomes in active erosive PsA to further assess the efficacy of Guselkumab in that radiographic progression and also see if there's any risk factors for radiographic progression. So the APEX study was a phase 3 ongoing multi-center randomized double-blind placebo-controlled trial in 247 sites in 29 different countries. It was started from June 2021 up until December of 2024. The inclusion criteria included PsA patients with disease of more than 6 months, meaning the CASPAR criteria or classification for PsA. They needed to have active disease, so having more than 3 swollen or tender joints with a CRP of greater than 0.3 milligrams per deciliter. They also needed to have the evidence of structural damage, so that evidence of poor outcomes of more than 2 erosive joints at baseline on radiographic baseline exams on either their hand or their foot. They also needed to have dermatological involvement of more than 1 psoriatic plaque and also or psoriatic nail changes. And they needed to be biologic or JAK inhibitor naive. Patients were excluded if they had any arthritis mutilants or any other inflammatory diseases that could have confounded the efficacy for their evaluations. If they had any history of unstable suicide ideation or behavioral problems 6 months prior to enrollment, they were also excluded. Also important to note is that some medications or therapies were not permitted prior to enrollment into the study, and these were pre-specified timeframes based on the different medications. So like topicals, 2 weeks was the time frame. Other systemics were about 4 weeks. So those patients, some therapies were not permitted prior to study enrollment. Patients were then randomized at a 5 to 7 to 7 ratio to either Guselkumab 100 milligrams every 4 weeks, Guselkumab 100 milligrams at week 0, 4, and then every 8 weeks, or a placebo group, which then had a crossover to Guselkumab every 4 weeks at week 24. In this case, concomitant medications were allowed if they were stable on those medications within certain dosing limits that were already predefined within the study. Patients could not be on more than 2 concomitant conventional DMARDs as well. What's interesting about this study is also that they had an early escape plan that at week 16, if anyone didn't have more than 20% improvement in baseline swollen or tender joints, they could opt for an early escape and they could actually increase the dose of one of the permitted concomitant medications. So that was actually pretty nice. And also to make sure that the study groups were well balanced, participants were randomly assigned after being sorted into 4 specific categories. The first one being a category of high variability between reading of the baseline radiographs. And then the other 3 level categories were based on predicted structural progression. So one being no progression risk, the other being low to moderate progression risk or rapid progression risk. And the stratification was based on prior PSA data or concomitant factors such as medications, their inflammatory markers, or how many erosive joints they had. Blinding for this study was pretty blinded and masked, so all patients in all groups had received basically the same number of pre-filled syringes and injections. Looking now at the outcomes, the primary outcome was a clinical response, so the ACR20 by week 24. And then the secondary outcome is mostly focusing on radiographic response. So the major secondary outcome was looking at the least squares mean change from baseline in total PSA modified VTHS score. Other secondary endpoints were looking at more stringent, achieving an ACR of 50 and 70, achieving no radiographic progression, and minimal disease activity at week 24. And they also looked at skin efficacy, so patients that had more than 3% BSA or IgA of more than 2 at baseline, and their responses rates of achieving 90% or 100% in PASI, clear to almost clear or completely clear skin at week 24. So looking at statistics, the primary endpoint was analyzed with the Cochrane-Mansell-Hansel test. The major secondary endpoints were analyzed via ANCOVA, and both endpoints were analyzed and compared with multiplicity control. And then overall, the type 1 error was calculated at 0.05. And they had a 99% power to achieve for an ACR20 score. Results of this study, there was 247 sites with screening over 2,800 patients. About 1,000 patients were randomized and 34 patients were from Ukraine sites. And during that time of escalation, those patients were excluded. And the end result was about 1,020 patients in total were included in the study. Based on the radiographic stratification at baseline, there was 57.6% had no progression risk, and about 7% had that high radiographic variability. And the discontinuation rates amongst all groups were pretty similar. Baseline characteristics were also well balanced, about 53 years of age with 55% male, mostly white, with moderate to severely active psoriatic arthritis, with the burden of disease about 7 years. So pretty similar to what we see in our patient population, right? So they're not all newly diagnosed. And they also had moderate impaired function. So definitely patients that have established PSA. So looking at the results of this study, the primary endpoint based on clinical response was the ACR20, and that was achieved in 66% of those in the every 4-week dosing and 68.3% in the every 8-week dosing. That was statistically significant. They also found that there were significantly higher proportions in the Guselkumab groups that achieved a more stringent ACR 50 and ACR 70. And the separation from Guselkumab versus placebo was seen as early as 8 weeks. So really rapid results and very early distinction of clinical impact. Also, now looking at the major secondary endpoints and that radiographic progression, they found that both dosing regimens of Guselkumab significantly impaired radiographic progression with less erosions by week 24 versus placebo, with an LSM change of 0.55 at every 4-week dosing, 0.54 at every 8-week dosing versus 1.35 in the placebo. They also found that overall, Guselkumab had treated patients had no progression of structural joint damage by week 24. And then looking at other manifestations of psoriatic arthritis, they found that Guselkumab had improved dactylitis, had improved enthesitis, had improved physical function. Looking again at nail and skin, Guselkumab, about 60% of patients that had a BSA of greater than 3% and an IgA of more than 2 Higher proportion again in those Guselkumab groups had achieved clear to almost clear skin versus placebo, while those in placebo actually ended up having worse nail disease. And then looking at safety, so every time we think of these options for our patients, we always think about safety. This, especially in psoriatic arthritis, new onset IBD was not seen in Guselkumab. So that's also something to consider when we think about our PSA patients. Infection was the most common risk of ADRs, with URIs and COVID being the most frequent. One patient had appendicitis, 2 pneumonia. One patient did have a MACE event, and they had, unfortunately, multiple CVD risk factors. There was 1 death due to COVID and 2 malignancies of prostate and renal. Anti-Guselkumab antibodies were detected in about 6% of each dosing group, but they were mostly low titers, and neutralizing antibodies were very uncommon. So some strengths of this study was that it was a large sample size with high retention. About 96% actually completed the study. They used validated scoring. They had a centralized scoring system and team that was blinded. They had a really high enrollment of active erosive disease patients. And the randomization strategy, accounting for reader radiographic variability and also the predicted risk of progression, helped balance basically the key risk factors that we're looking for in our psoriatic arthritis to predict that radiographic progression. And then some limitations to the study was that the placebo control duration was about only 6 months, especially in patients with active disease. That's kind of relatively short term to really try to see like their long-term outcomes of structural damage. I know that you can start to see within 6 months early structural damage, but that is a little short for the study. And also nail disease. It was also within those 6 months. Usually it takes a little bit longer. There's also a high placebo response that they found, and enthesitis and dactylitis measures are often always based on manual exam and may be affected by confounding comorbidities. So in conclusion from this study, the trial met its primary endpoint of ACR20. It also met a major statistically significant secondary radiographic endpoint at week 24. So both Guselkumab regimens significantly inhibited radiographic progression compared to placebo in biologic naive patients with active erosive psoriatic arthritis. Guselkumab inhibited progression of erosions as well as joint space narrowing and produced high rates of non-progression to radiographic progression. So really stopping and halting that radiographic progression that we saw in specifically Guselkumab group versus placebo. And then along with other multiple domains, as often as we see our patients with psoriatic arthritis, they don't only present with one domain of function. But with the Guselkumab group, it also included and also showed improvements in physical function overall, skin, nail disease with no new safety signals. So another great option for patients, especially in those that may progress to our radiographic changes. It may be great to start with Guselkumab early on because it is not only stopping the progression of radiographic disease, but also treating those multiple psoriatic domains. So if you enjoyed this journal club and would like to see more, please visit our RAP.org website and click on our RAP content room and also visit our RAP ACE app. Thank you.